Our first speaker today is Dr. Siva Kumar. Dr. Kumar is the Deputy Head of the Cardiothoracic Department, Senior Consultant Cardiothoracic Surgeon at the National Heart Institute in Malaysia. And Dr. Siva Kumar specializes in complex pediatric cardiac surgery, and he's been performing the AVNeo procedure since 2015. And he's completed over 50 AVNeo cases. And I always appreciate hearing from Dr. Siva Kumar because Dr. Siva, he brings a broad experience level, and he always has some new thoughts and ideas to our webinars. So I do appreciate Dr. Siva for joining us today. Our second presenter will be Dr. Sayed. And Dr. Sayed is an Associate Professor, Division of Pediatric Cardiac Surgery at the University of Minnesota. And Dr. Sayed completed his medical education in Egypt and then had some fellowships in pediatric congenital surgery at Stanford, at Lucile Packard Children's Hospital, and at the Mayo Clinic in Rochester, Minnesota. So I'm very excited to hear from Dr. Sayed as he explores a novel new way of thinking about how to use the AVNeo. And with that, I would like to ask Dr. Siva Kumar to get us started.
Thank you, Damon, for the kind introduction. And hello to all the participants from different parts of this world who have come over to take your time to listen to this webinar. This is the second of the series of the webinars that have been held focusing on the AVNeo procedure in the pediatric population. I would like to thank Mr. Damon Lawson from JOMDD for organizing this webinar. In the last webinar, I focused on the surgical aspects of AVNeo procedure. In this webinar, I will compare the AVNeo procedure against the conventional valve repair techniques in the pediatric population, and hopefully this will shed some light on how I can convince you all whether the AVNeo would be the way to move forward in the near future. So I have no financial disclosures except that I am a proctor for the AVNeo procedure appointed by JOMDD. My presentation outline for today would be, I'll highlight on the background of aortic valve disease and the principles of the management. And I will talk about some of the technical aspects of aortic valve reconstruction. And I'll share some historical data and our own institutional experience on the conventional aortic valve reconstruction techniques. And then I will move over to some introduction on the neocuspidization repair in the children and our own institutional experience on the AVNeo procedure. And last, I would like to share with you why is it that I prefer to do the AV neocuspidization repair in the pediatric population. Now, following Alain Carpentier's French correction for mitral valve repair, El Khoury in 2005 proposed the functional classification of aortic valve abnormalities. For the first time, we had a clear, standard, predetermined surgical strategy guided by pathophysiological analysis of the aortic valve. However, if you look at the long-term freedom from reoperation in this group of patients, it is very clear that those patients had failure of repair with those who had the restrictive valve lesions, wherein you did not have adequate tissues to perform the repair. So the quality of the repair basically comes from how the quality of the tissues are going to be. Now, if you look at the quality of tissues that you use for repair or reconstruction, you have two kind of scenarios here. One, you have tissues with excess amount of tissues for repair, which is pretty standard. You can either perform a central plication or a lateral plication, and most of the patients will go on a repair technique. The second scenario is wherein you have patients having lack of tissues for the repair. So they will be classified as a complex aortic valve disease, and most of them have a mixed and regurgitant kind of lesion. So you really need to use some form of additional tissue for repair. So in this scenario, you have two possibilities. Either you will replace the valve or you will attempt to repair. Now, when it comes to the pediatric population, the valid tools that are being developed for the adult pathology is not optimal for two reasons. Number one is the complexity of the lesions. In the pediatric population, the disease of the valves are more of a stenotic type, so you do not have adequate tissues to perform the repair. And furthermore, you lack a rescue therapy wherein if your valvuloplasty procedure fails, you don't have an option of using a bioprosthetic valve. The only option that is left is either you place a mechanical valve or you perform the Ross operation. The second issue comes about with the surgical timing. And this depends on the valve phenotype, whether it's a unicuspid, a bicuspid, or a tricuspid valve, because depending on the pathology, the timing will change. You may have to operate early or later in life, and also the age at operation. Because the younger the age you're going to operate, there are going to be more complex lesions. That means there's going to be a higher chance of reoperation in the future. Now, if you look at the long-term results of the Ross operation, you can see that though the overall survival is pretty good, over 15 years is about 85%. But if you come to the freedom from reintervention in the left ventricular outflow tract, it drops down to about 59% in over 15 years, and the reintervention rate is higher on the adolescent group. Similarly, the reinterventions on the right ventricular outflow tract, you can see that in 15 years, the freedom is about from reintervention is about 50%, and the higher the reinterventions in the infant and the children. So looking at these results, it is clear that at some point in time, they will need some kind of reintervention at either the right ventricular outflow tract or the left ventricular outflow tract in all age groups of the pediatric population. Furthermore, the Ross operation also depends on the quality of the pulmonary homograft that you obtain to use the right ventricular outflow tract, and not all parts of the world has the access to that. And there's always a concern of the late dilatation of the autograft, especially in the developing nations where rheumatic pathology is predominant. And there's always a concern, though not in the mind of the purists who believe in this operation, that you are essentially converting a single valve disease to a two valve disease. Now, coming to the mechanical aortic valve replacement has been widely used lately, especially with some of the valves where you can reduce the dosage of the anticoagulation. And this results from the Boston Children group shows the reoperation rate of about 78% at 10 years. And the highest chance of reoperation is in those younger patients who had smaller size valves implanted. And also this study has shown that in nearly a third of the patients, some form of a root enlargement procedure has to be performed in order to implant a suitable sized valve. Then again, these patients will need anticoagulation for lifelong, and that will have an adverse effect on the lifestyle of the patients. Now, there have been a lot of different types of aortic valve repair techniques that have been mentioned in the literature, starting from the simple plication techniques for excessive tissues, wherein you can do a lateral plication or a central plication. You can do a single cusp replacement, or you could do procedures such as a cusp elongation or a valve elongation procedure, or you can just place some kind of a pericardial patch to close some perforations. So these techniques have been there for a while, and we have had a lot of a series of publications that have come about showing the short-term and the long-term results in different pathologies. And if you look at the overall freedom from reintervention from all these studies, shows the at 10 years the reintervention rate is nearly 45 to 60%, and the freedom from valve replacement at 10 years is about 55 to 75%. So in our own series over the period of 25 years, we had performed about 105 patients with for aortic valve repair procedure. The numbers have not been very large. The reason being, we have been pretty conservative in the valve repair techniques, because many of our patients came under the rheumatic age population, and these patients had initially undergone the Ross operation, and the failure of the Ross in this group of patients were pretty stalking, and that's why we had stopped the Ross operation, and the aortic valve repair had taken some precedence over the years. And most of the patients that we had operated were on ventricular septal defect closures, who had come with late presentations, who had some form of severity in the aortic valve regurgitation, who had undergone surgery. So most of the patients in our cohort has been surgery with pure regurgitant lesions. So the overall freedom from reintervention at 20 years in our population was about 65%. But mind you, we were not able to complete our follow-up on all these patients, because a significant number have lost to follow-up. Probably these estimates may be, probably these results may just be an underestimate, and and probably the failure rate may be even more. So if you look at all these techniques that are taken into consideration for currently in the pediatric population, encompassing for the simple lesions and complex lesions with the different kind of valve repair techniques and the various form of valve replacement techniques, the AVNeo procedure is increasingly gaining acceptance as a new string to the bow in the armamentarium of aortic valve interventions in the pediatric population. Now, one of the advantages of the AVNeo procedure, from my experience, is that it's all pretty determined, because you have sizes that come in different shapes, wherein you can size the leaflets appropriately, and then based on the sizes you can shape appropriate sized leaflet based on the designated templates. And in fact, you have specific marking points where you can place your sutures. So I believe that with some discipline and repetition of the procedure, it is almost impossible to make any errors in performing the repair of the AVNeo technique. Now, from the physiological point of view, one of the salient features that favors the longevity of the repair and which has been evident from the adult population, which was described by Professor Ozaki, is the increased coaptation zone of the newly constructed pericardial cusp compared to the native cusp contact point. So this is indeed of significant advantage in the pediatric population, because I believe that this would be the principal factor to improve the durability of the valve, as the increased coaptation zone will ultimately compensate for the growth of the native annulus, wherein the coaptation height may reduce as the annulus is growing, but you will still be able to maintain the adequate coaptation distance of the constructed cusp. Furthermore, this also helps us to widen the scope of performing this technique of repair in severely regurgitant lesions. Now, if you look at the current surgical indications for the AVNeo procedure in the pediatric population, it's not only indicated in a congenital aortic valve disease, it's also gaining acceptance in acquired heart disease such as endocarditis and rheumatic heart disease. And the indications have also been extended into patients having small annulus, wherein in the past you'd probably do a Ross operation. You can still perform some kind of root enlargement and perform the AVNeo procedure. And in those patients who had a previous prosthetic valve implantation, when they come in for a change of prosthetic valve, you can probably go ahead and perform the AVNeo after explanting the prosthetic valve. And it's also getting widely accepted in the adult congenital heart lesions, especially in conotruncal lesions such as post-truncus arteriosus operation or arterial switch operation. And now it's also come in as a part of the valve sparing root repair, such as the Ozaki David or the Ozaki Yacob procedure. And also it can be used as a substitute valve in the Benthal operation, and where it's been described as the biobenthal procedure. I personally do not have experience on the biobenthal and the valve sparing root type, but this has been explained by the Boston Children's Group, where they have quite a substantial experience on performing this procedure. So in the last 5 years, we had performed about 50 patients in the pediatric population with the AVNeo reconstruction. At the time of the surgery, in our early stage of the operation, two had failed during the implantation itself. So we abandoned the procedure and placed a mechanical valve in those two patients. But the remaining 50 patients had a successful AVNeo repair, predominantly in the male population. And most of the patients had a tricuspid valve lesion, because many of our patients, about a third of our patients, were in the rheumatic age group, had rheumatic pathology, and most of them, in fact, came under the congenital aortic stenosis, either as an isolated lesion or as a post percutaneous valvotomy. Predominant nature of the aortic valve disease was regurgitation, followed by mixed valve disease, and a few patients had previous procedures done. And if you look at the overall survival over 4 years has been 94%. In fact, we had two mortalities, both were related to endocarditic patients. The first patient was a patient who had acute endocarditis, who underwent a successful AVNeo procedure, but unfortunately had a ruptured berry aneurysm, and the patient passed away due to intracranial bleed. And the second patient was an unfortunate teenager who underwent a successful AVNeo procedure. had been admitted in another hospital with the aortic root abscess, and by the time the patient could be transferred to our care, had passed away. So both the mortalities were not related to the procedure, but due to complications related to endocarditis. And the overall freedom from reintervention was 87%. We had no failure in the immediate post-operative period. Both the patients had reoperations because of endocarditis. One patient had endocarditis 6 months after the procedure, and then we had to perform a redo AVNeo procedure. And the second patient had endocarditis after 8 months, and this patient came in with the root abscess. So we had to explant, we had to debride the root and place a mechanical valve. So both the patients, the reoperation was not related to the procedure, but it's as a complication of endocarditis. And all these patients, you can see that the post-operative gradients had significantly dropped after the procedure, and they remain to be within the acceptable range even on the recent follow-up. So that means there's not been much of a stenosis of these lesions despite the increased coaptation height. On the latest follow-up, there are only 2 patients who have been having followed up with a moderate aortic regurgitation, but they remain asymptomatic, so they just been on follow-up. But the rest of the patients are still remaining in with the nil aortic regurgitation or a mild aortic regurgitation. Now, I would like to talk to you some of the special considerations to which the AVNeo reconstruction has a distinct advantage over the other forms of aortic valve repair techniques. And I believe because of these special considerations, that the AVNeo reconstruction would probably be a good substitute for valve reconstruction in the pediatric population. Now, if you have a patient who had a previous AV valve neo and has developed some kind of a failure of the valve, you can still go ahead and re-repair the valve with another AV neo procedure. To show an example, I have this 7-year-old kid who I had explained earlier with a mixed bicuspid aortic valve lesion with the AS and AR, and had a balloon dilatation at 2 years. And this kid underwent a successful AVNeo reconstruction, but within 6 months came in with endocarditis and was put on antibiotic therapy for about 6 weeks. You can see the huge vegetations and dehiscence of the valve. So we took the kid back and performed a redo AVNeo reconstruction, this time with the decellularized bovine pericardium, and we had a successful repair, and we are still following up this patient. The initial gradient was about the mean of about 10, and that gradient on the latest follow-up seems to have dropped even further. So the next concept is using a single leaflet valve repair, because most of the time the Ozaki or the AVNeo procedure is performed by a tricuspidization technique of the aortic leaflets. But there are indications wherein you can just perform a single leaflet valve repair. And in this case, I can share with you our experience on the syndrome of VSD with aortic regurgitation, otherwise called the Lobry-Pedzi syndrome, wherein there is a dilatation of the aortic sinuses with the lack of support of the annulus, and causing a downward and outward displacement of the sinus of valsalva and the annulus, leading to a lack of coaptation between the aortic cusp. So in this case, what we essentially do is we close the ventricular septal defect, and then we will just change one leaflet of that's the right coronary cusp, because that right coronary cusp is sitting exactly where the defect is, and that selectively prolapses. Most of the time what happens is when we replace this cusp, we can see that the coaptation height goes higher up compared to the other two native leaflets. But over the period of time, that kind of, as the annulus kind of remodels, that valve height slowly comes down and is kind of fairly seated in equal height compared to the other two native cusps. This indication, to be honest, I think it only works when you have a doubly committed subarterial VSD, which involves only the right coronary cusp. I have tried this on a patient who had a kind of a perimembranous or outlet type of a VSD, but this technique did not work. I think in that kind of instant, probably you have to replace all the three leaflets. And I think this particular indication, I can show you with an example in an 8-year-old girl who had a subarterial VSD with a moderate aortic regurgitation, the prolapse right coronary cusp into the VSD, underwent a VSD closure and a single leaflet AVNeo reconstruction. You can see in the post-operative period, the valve is coapting well with just a central, small central jet. There's also another indication for a single leaflet AVNeo, which the Boston group have described, especially in the bicuspid aortic valve, wherein they use the two native cusps to reconstruct the left and the non-coronary cusp, and the huge defect that is left can be reconstructed with the help of the sizers to measure the right coronary cusp, and you can effectively replace that single cusp of the right coronary, maintaining the other two normal leaflet. This does have an advantage because you are just replacing one leaflet and you are still preserving two other native leaflets. So probably this might help in maintaining the repair, but we probably need to see how the long-term results are going to be. Now, if you look at the repairs for unicuspid valves and bicuspid valves, there's been a lot of interest lately describing the bicuspidization kind of repair in the unicuspid valves with good intermediate term outcomes. But we have now adopted a tricuspidization of the unicuspid valve. You can see this 12-year-old lad who presented with a unicuspid valve with mixed aortic regurgitation and aortic stenotic lesion. And he underwent a successful tricuspid AVNeo repair. Again, you can see that the valves are coapting pretty well, and you can see the good tri-leaflet configuration with no aortic regurgitation. And this patient is doing well in the follow-up of about nearly 4 years. So this was in the early time of our experience. Now, if you look at bicuspid valves, traditionally you can do a similar kind of repair that is being described by Rene from Switzerland, using the so-called native tissues to create two cusps, and then using autologous pericardium or a bovine pericardium to replace one of the cusp. Besides that, you also have what is now widely accepted is the leaflet cusp augmentation procedure for the bicuspid valves, wherein many adult surgeons have reported good results in the medium term. But the reason why we have shied away from performing a bicuspidization repair is that if you look at this circular model here, if you take the length of the free edge in a bicuspid valve, is certainly smaller than the length of the circumferential length of the annulus. So if you do just a elongation, cusp elongation repair, you can see that because this length is shorter than the circumferential length, so that really does not completely open and close the valve leaflets as good as a tri-leaflet configuration, wherein you can see the length of the free edge in a tricuspid repair is the same as the circumferential length. So this will give a good point of opening and closure, and that I believe will probably maintain the long-term durability of the repair. And this has already been explained by Professor Ozaki in the adult population. And though contrary to what the thought is, whether is it possible to do a tricuspidization, the answer is yes. There is a bit of a technique that is involved, which is not as simple as the performing it in a tri-leaflet diseased valve, because you need to really mark the position of the newly created commissures and the suture and the suturing area. So, but invariably you can get a good repair by performing a tricuspid reconstruction. This is a 8-year-old kid who had a severe aortic stenosis, had a balloon valvuloplasty at the infancy, and came to us with a mixed aortic stenosis and regurgitant lesion. So this child underwent a successful tri-leaflet replacement of the aortic valve using the AVNeo technique. I can see that the coaptation is pretty good with no regurgitation, and the gradient across the aortic valve is pretty minimal. So there have also been procedures such as root enlargement being explained by the Boston Children's Group, and they have published their series on performing annular and root enlargement, and at the same time performing the AVNeo. So in this instance, probably you don't have to replace a mechanical valve. You can perform the root enlargement and place a sizable cusp of the using the AVNeo technique, and probably this will both alleviate the obstruction at the left ventricular outflow tract, and at the same time maintain a good tri-leaflet configuration of the reconstructed valve. The biobenthal is another technique that probably will come into use in the near future, but there have been some reports on the success of this technique. Well, one of the most important things that I'd like to highlight when it comes to in our experience on the AVNeo procedure is the infective endocarditis prevention, because we had about 3 patients with infective endocarditis, and that happened pretty early after the surgery. So what we have now done is we have moved towards using disposable sets from the reusable sets. So I believe that probably using the disposable sets are better, because I'm also concerned about the the repeated use of the reusable set. And also when you harvest the pericardium, I think it's absolutely important to remove all the fatty and the areolar tissues around the pericardium, because if these tissues are still left out, they will probably form a nidus for infection. And I routinely put all the patients on a 6-month aspirin therapy, so that that is the time period where the biofilm formation can take place on the leaflets. So if we can continue the aspirin for 6 months, can prevent the biofilm formation, and subsequently reduce the chance of developing an endocarditis. One of the most salient features I think on the AVNeo repair technique is it's pretty well established, and I think that all surgeons who would like to embark on this procedure should not have a problem to get a successful program going with the AV repair technique. the surgeon has to have is a complete understanding of the aortic valve complex, and need to undergo some dry lab sessions using these training models. And these training models have been widely used for performing this repair, and it's been extremely useful, because with this kind of training model, the surgeon is able to perform the procedure, and also at the same time able to critique his technique, and if there are any shortcomings, he can probably make the necessary changes in the training model, so that when he goes to the real time, he will not have any problems. And I believe that with undergoing such training based on these training models, and also being proctored by some of the experienced surgeons, I think it's pretty much a foolproof operation. All the surgeon needs is to just follow the steps as it is being described, without at least in the initial phase, not to make any modifications. And with some kind of discipline, I think you can get uniform results for all the cases. I personally, as a proctor, have been to nearly I think 7 centers all over South and Southeast Asia. And to my surprise, I had only taken the surgeons through the training model. But in fact, the first case itself, the surgeons were able to perform the procedure without any problems by themselves, under the supervision of the proctor. So based on that, I think this procedure is pretty well established, and I think in the years to come, the surgeons, the younger generation who would like to embark on this procedure, certainly need not have any fear, and you can do it with a lot of confidence. So now, from our experience over the years, we have now kind of developed a treatment algorithm for aortic valve disease in the pediatric population. It's a congenital aortic valve disease. If it's a neonate, an infant, the interventionalist will perform a valvotomy, and afterwards we'll either subject the patient to a Ross procedure or an AVNeo repair. In a child who's less than 12 years of age, if it's a mixed aortic stenosis or a mixed lesion, we will go ahead and perform an AVNeo. But if it's a pure aortic valve regurgitation with the dilated annulus, then we may still continue AVNeo, or otherwise we'll place in an aortic valve, mechanical valve. But in female populations, even in severe AR, we'll try to go towards AVNeo to avoid placing a prosthetic valve. In older children, we still go ahead with if it's a mixed lesion, we will go on the AVNeo pathway. But if it's a purely regurgitant lesion with a dilated annulus, at the moment we still perform the mechanical aortic valve, except it's a female patient. For acquired lesions, similarly, in the neonates and infants, if we are able to perform the AVNeo, we will do that. Otherwise, we will either go in for a mechanical valve or a Ross operation. In a child less than 12 years with a small annulus, we will perform an AVNeo. If it's a large annulus with a severe regurgitation, probably will go on the pathway of a mechanical aortic valve. Except if it's a female patient, then we'll still consider AVNeo to avoid placing a prosthetic valve. If the older patients who are 12 to 18 years, with a small annulus, we will consider the AVNeo procedure. If it's a large annulus, then we will still go ahead with the mechanical aortic valve replacement, except in the female population. Our concerns why we are still not comfortable to use the AVNeo in the purely regurgitant lesions with large annulus is we are still not sure what the long-term outcomes are going to be. But hopefully, with the results that are coming off in the midterm, if it's very encouraging, probably our way to move forward would be to go away with the Ross operation, to go away with the mechanical valve replacement in the congenital lesions, and also in the acquired lesions. And hopefully, the AVNeo would be the gold standard of repair for aortic valve reconstruction in the pediatric population. Thank you very much.
Thank you very much, Dr. Siva Kumar. Excellent, as always, presentation. Dr. Sayed to take over and do his presentation.
Thank you. I'll share my slides here in a second. We had a similar experience with the aortic Ozeki, similar to others, in the point of also used one leaflet and tricuspid reconstruction of the aortic valve and patients with reoperation where there's no pericardium. And then we start thinking about the pulmonary position and why not to try to approach that from a point of reconstruction as well, if we can. And we have met with some challenges, so we learned a few things, and we would like to share with you about what we've done so far. In overall, there is not a big experience, so we don't know the answers for a lot of questions, but I believe in the literature as well, there's not much information about this topic. Moving forward, we'll talk about what we call pulmonary Ozeki. This is my disclosure. The outlines pretty much follow what the previous presentation was from a point of what are we doing right now from a pulmonary valve intervention standpoint. The current indications, the available surgical options, and the role of the Ozeki procedure. Actually, will there be a role at all, and the current outcomes, and where we're moving from there. The pulmonary valve, is known always as the least appreciated and most poorly studied cardiac valve. And part of the challenges with that is its location, because it's very difficult to get proper imaging in contrast to the aortic reconstruction. And we see more of the congenital pathology in the pulmonary position in compared to the acquired pathology. Is a list of most common pathology that we deal with, and I'm sure a lot of us have seen varieties of these. So the situation in the acquired pulmonary problems are really limited to some endocarditis cases. We've seen several carcinoid heart disease, rheumatic still, although less common. So we're talking about the congenital pulmonary stenosis as a most common variant, and those who had previous intervention on the pulmonary valve as part of more commonly tetralogy of failure repair, some other supravalvular combined with valvular stenosis, like patients with Alagille and Williams syndromes, etc. So it's a little bit of a different spectrum in comparison to the aortic. So what do we have for treatment options? So if we are trying to, or at least that's my point of view, if we are trying to present this to a cardiologist and say, we have a new option that we are offering you guys to talk about the pulmonary valve reconstruction and repair, they will say probably, why do we need to do that? We have much better options. So I wanted to start by showing the limitations of what we have right now, so we can think about how can we move forward with a new procedure. So in general, we have pulmonary valve repair as well. We have transcatheter options, which is really taking a lot of these patients, starting from the percutaneous balloon valvuloplasty, and then currently the transcatheter implantation, whether in previously repaired or replaced pulmonary valves, or in native outflow tracts, such as after transannular patch and tetralogy repair. And also from a surgical standpoint, we have a lot of options that's actually good options, such as homografts, pipe prosthesis, and we've also used mechanical valves in the pulmonary position. And I'll go briefly over pros and cons of each one before we move to the current proposal. So the percutaneous balloon valvuloplasty, as we know, it introduced in the 80s, and currently it's a first choice therapy for congenital isolated pulmonary valve stenosis. Probably very difficult to get these patients for surgery in the current era, especially in centers where the balloon valvuloplasty results are quite good. However, there are suboptimal results, and this is from the valvuloplasty and the angioplasty registry. Younger patients at the initial percutaneous balloon, those with dysplastic pulmonary valve, or they have a small annular diameter, the higher the initial gradient, and some patients with no-NAN syndromes as well. And these are the patients where we think there could be a better options to offer surgically in comparison to the balloon. And also these are the patients where are difficult to place a standard satisfactory size prosthesis without having some gradient in the outflow tract. The reintervention for residual pulmonary stenosis is about 10 to 15%, and moderate to severe pulmonary regurgitation is about up to 60% in some of these patients after the balloon. The freedom from death or reinterventions goes into the 80% at 10 years post-balloon. So bottom line is there is about 2 to 3% of these patients who will need pulmonary valve replacement at some point. The standard, the transcatheter therapy, has been used more for the conduit, previous conduit failure, and those with previous pulmonary pipe prosthesis. The challenges are in those with large native RVOT because of the large diameter and the difficulty in securing the transcatheter valve there. And we see this commonly with tetralogy patients and those who had previous balloon. These are some of the available options, and we all know the Melody and the Sibian valves were currently approved to pre-market for pulmonary valve replacement. The self-expanding Harmony is out there, and it's currently enrolled in a trial for a native RVOT. So that's our future challenge. And a lot more of these transcatheter self-expanding valves have been developed, and still we don't know the data after with these prostheses, but it's been done. And an example of this patient that we may never see is a patient who had a balloon valvuloplasty for a congenital pulmonary stenosis and underwent a Harmony valve replacement, and he's 18 years old, so probably can have another valve in valve, etc. So these are the type of challenges that we have to prove that any procedure we propose have to have a better results or at least an equivalent results to what we have right now. This is a recent comparison between the percutaneous and the surgical pulmonary valve implantations. And this includes over 5,000 patients with mixed spectrum. It's a retrospective study, so there is still some limitations, but it shows you the trend of the valve interventions percutaneously and surgically. This is only in the last from 2016-2017 period. The comparison, the bottom line between the surgical and the percutaneous valve options are important to know, because you can see based on these data that the length of stay, the mortality, and other early complications, it's overall low. However, in some of these ones that marketed by Star are significantly more in the surgical group in comparison to the percutaneous interventions. Mortality is not much difference, but the length of stay and other peri-procedural issues are more common in the surgical group. So moving to what we do surgically for the pulmonary valve currently, one option is pulmonary valve repair. Most of the patients that we see are those who underwent a previous type of repair during infancy, and most commonly tetralogy or fellow. The patients who had the previous transannular patch, the transannular patch can be removed, and if the annular size is adequate, you can try to bicuspidize this valve in a way of bringing basically both leaflets together at the anterior commissure here. This type of procedure, of course, require planning during the infancy period and during the initial repair. So you can do that later, preserving the patient native pulmonary valve as a better option than replacement. Now, we don't know the long-term data from this yet. However, now this was before the era of the Ozaki, and we recently did a similar case where we used the one leaflet Ozaki to reconstruct that anterior commissure and left the two leaflets of the patients intact, which will be better than any prosthesis. So there is more ideas comes as we deal with these challenging problems. This is the way that we do the surgical pulmonary valve, and I'm sure a lot of us follow the same strategy of this is again another example of a patient who had a previous we'll show you the video here, another patient who had a previous tetralogy repair, so no autologous pericardium anymore. We use a bovine pericardium to reconstruct that hood. We try to put a larger prosthesis. These are all the concepts that we are trained to do with the idea planning the next intervention to be of a transcatheter intervention. My observation with these techniques is there is limitations to it. Despite you can get an adequate size prosthesis, but I don't believe that the hemodynamics are good in a way that we are expecting, because you have a rigid prosthesis in the outflow tract. It's not uncommon to have the wrong orientation. I've personally operated and seen patients who underwent bioprosthesis placement in the outflow tract, and the valve was not oriented right, and the patient still had obstruction, and the prosthesis itself is working good, but some of these patients are challenging to get the right access and end up by replacing the valve to get a better hemodynamics. Now, will that change? This is exactly the same field that we see when we come back to try to replace the pulmonary valve on a patient who had tetralogy. So the way of the reconstruction here, if we are thinking about an autologous pericardium or a bovine pericardium without a prosthesis or a Ozaki type procedure, this is how we have to build it through this. So it requires a little bit of modification to the original description of the Ozaki. I wouldn't waste a lot of time here, but this is, kind of the final product. We also use the mechanical valve, and in some patients is not a bad option. Depends on how the number of the operations, and the downside, of course, is the need for anticoagulation, and the data from this mechanical prosthesis in the pulmonary position, it can reach up to 20-30% rate of thrombosis. So it's also not without its downside, but the technique is more or less similar. And whether you start the patch from the top or the bottom, it doesn't really matter. In a lot of these patients, you can easily place a prosthesis there. So with all the options, and of course there is the homograft option as well, which is we all familiar with. So with all these available options, why do we need to add another one? Well, we have to understand what the limitations of what we have right now is. So we believe that there is a need for some other ideas. The limitations of the transcatheter therapy, as I've mentioned, the patient size and weight is not always possible. Especially in the smaller patients. Also, those with native RVOT and large transannular patch, there is about almost close to 50% failure rate for this transcatheter intervention in this position until we have more robust data about the new type of prosthesis. Endocarditis, especially as we all know from Melody data, so it's not a small risk in comparison to surgical options, and inability obviously to address concomitant cardiac pathology, which is not uncommon with these patients. Tricuspid valve issues, residual shunts, branch pulmonary artery pathology. So these are the patients that we will be dealing with. Surgical options, of course, are not great either, because you have up to 50% or so re-intervention within 10 years from placement of the prosthesis. These are children and young adults that we're dealing with, so thinking about other options is important. We already mentioned the limitations of the mechanical prosthesis, limitations of the tissue prosthesis, also they can thrombose the tissue prosthesis in the pulmonary position. We personally anticoagulate all patients with pulmonary position for 3 months, similar to other pipe prostheses. Now, this is a little bit difficult in children because of the limitations obvious about the anticoagulation. So we just place them on aspirin, but we don't know the result of this. When we compare the homograft to the pulmonary valve replacement with a pipe prosthesis, it's clear that the homograft has a better hemodynamics and lower gradient, and when compared with the pipe prosthesis, the risk of reintervention or structural valve degeneration is also lower. But of course, we have also limitations for the homografts from the cost standpoint and also from the availability as well. And the procedure is a little bit different than the standard. It may require more dissection in a reoperation to try to remove the previous conduit, things like that. Moving forward about the idea of using the patient own pericardium or another type of pericardium in a pulmonary position. So looking at the literature first, what do we have out there? We don't have much information. The data that we have are very limited to a handful of patients with a common scenario between all of them about endocarditis. So this is an example of a patient who underwent, is an adult patient, 32-year-old, who underwent reconstruction of the pulmonary valve with autologous pericardium using the authors describe using a Ozaki technique for endocarditis. However, they did not use the actual sizing of the leaflet and as standardized by the Ozaki group. This is how they measured and determined the length of the leaflet and the height by measuring using a pieces of silk to reconstruct the leaflet. The sewing technique itself is the same. So and they called it as an Ozaki repair. So endocarditis is the first patient. The follow-up in this publication was not really clear. What was the follow-up? But it wasn't mentioned. Another case of, again, endocarditis using pulmonary valve neocuspidization. The follow-up in this series was 3 months. And again, the reconstruction here was not based really on the Ozaki sizing, but it is described in the paper as Ozaki technique. So we can take this with caution as well. 3 month follow-up, that's what mentioned. And the way they sized it, basically they sized the annulus into a 19, and then they created the leaflet with the same size. Another case where a patient with pulmonary artery aneurysm and presented with pulmonary regurgitation, and the authors replaced the pulmonary artery and they did a 1 leaflet Ozaki reconstruction. They kept the 2 leaflets that the patient have because they were normal, and they added another leaflet, but they used the sizes of the Ozaki and they used the actual sewing technique. The follow-up here is about 10 months, and it seems like only trivial regurgitation that was reported with low gradient in the outflow tract. Now another one with endocarditis. Again, this was an interesting story of aortic and pulmonary valve endocarditis, and in a 24-year-old pregnant female who had the endocarditis during pregnancy and had the surgery after delivery. The authors used a tricuspidization of the pulmonary valve using autologous pericardium. It strikes to me that it looks quite thick in these cases, not the typical Ozaki pericardium. And I assume with the endocarditis, these patients may have also some pericarditis, which may not be, I don't know if that's the right choice. You can see the edges of the pericardium also folded a little bit. So, but so far, this is also, again, 3-month follow-up with good coaptation height, described as 10 millimeter, which is what you expect with Ozaki. So again, limited follow-up, and we don't know what's going to happen. Now, this is the technique that was described by the Boston group. If a 16-month-old 7.5 kilogram child with Alagille syndrome who underwent a neonatal aortic valve balloon valvuloplasty and a PA-plasty and a pulmonary valvectomy at 6 months. And then the patient came back for a pulmonary valve replacement. The authors used bovine pericardium to reconstruct the pulmonary annulus and the leaflet, because obviously you don't have a good pericardium available for these patients. Now, the technique that was described is sizing and sewing. These are 2 leaflets that's sewn in, and then the third leaflet come with the more what we call this transannular patch. We did it a little bit differently, as I'll show you in a second. Because I feel like when you place the two leaflets, these 2 leaflets either will stay up in the air till you complete the third, so you can build the commissure, or it's easier to build up the circle first and then sew the leaflet in. Because it may require to move these commissures a little bit around. This is assuming that this width is exactly the same as the other 2 leaflets, or you end up by making different size leaflets. So these are the things that we start to face when we start trying to do this procedure, because the pulmonary anatomy is a little bit different, and the exposure also sometimes is different compared to the aortic. The follow-up in this series was quite good, at least 18-month follow-up with a little bit of mild pulmonary stenosis and mild regurgitation. So it is possible. So this is the outcomes of the current Ozaki. A total of 6 cases, 5 in adults, 4 with endocarditis, and 1 with pulmonary artery aneurysm. I call this 6 and 1/3 because 1 leaflet was used following this Ozaki. 16-month-old child. This was the only child in the literature that mentioned the pulmonary valve reconstruction, and this was the longest follow-up with 18 months with the bovine pericardium. I would say we personally don't use the cardiocell anymore in that position. At least we use the photo-oxidized one because I feel it's a little bit suitable for this position. Now, when we are thinking about the challenges that we are facing when we're trying to offer this pulmonary Ozaki concept, is first the patient profile. they are different, and I'll talk about it in a second. The current outcomes of the available options, so we have not to have worse results, and we can safely say that the transcatheter options are reliable so far, and that's a very difficult in comparison to the aortic valve choice. And also there are minimally invasive options for pulmonary valve replacement. So we are challenging ourselves, and the technically changes with the pulmonary position as well. So looking at the patient profile, in the pediatric population, so you really will be dealing mostly with those patients who had previous repair of congenital heart defect, where most commonly tetralogy, to be realistic. So these are the patients most likely they don't have autologous pericardium suitable for use. So we have to think about alternative or using the pericardium from some other areas in the mediastinum, such as the inferior pericardium or the posterior pericardium as well. Isolated congenital PS, unless there is associated supravalvular or subvalvular obstruction, probably less common to see this patient because they're going to go for balloon valvuloplasty. The adults population, now we have to think, with the exception of these rare circumstances of isolated endocarditis or carcinoid or tumor, etc., these are patients where the Ozaki will be an easy procedure to perform in these patients, as it was described in the literature. And some of the adult congenital, with being careful about the ability to produce data comparable to the transcatheter data here. But also on the other side, I think there is a forgiving nature for the pulmonary valve in many ways. Number one is you don't have to worry about the coronary position at all. So that gives us a little bit of freedom to put the leaflets anywhere we want. The second thing is you don't have to worry much about placing the pulmonary valve actually in the annulus, in the native annulus. I think there is a chance, and this has we've done this with prosthesis sometimes, is to place it not down in the RV, more into the pulmonary artery, where it's probably sometimes can be easier to do the reconstruction. And also, I think there are 3 different ways of doing it in a pulmonary position. So this is the typical harvesting of the pericardium after sternotomy, and this is more or less what we see as a pulmonary stenosis, where there is a little bit of annular hypoplasia, and in these patients, probably, or at least I personally will have to extend the incision in a vertical fashion, because you have to enlarge the annulus in this patient to be able to place the valve or the leaflets. So we'll open it with varying extension into the RV outflow tract, taking all the obstructing muscle bundles out, and then building the leaflets in the classic fashion with the templates. So we will size it, and we'll create 3 equal leaflets. I don't think we need to make difference much from the aortic position. And then this is where I will start. I'll start by completing the circle first, in a way to make it easy on how we judge the size and the location of the commissures. So once you complete the circle, you really can sew the leaflets in more or less a pulmonary aortic fashion type. Now, one thing that we encountered is that posterior commissure. This is a little bit different than the aortic position, because I feel sometimes, especially in bigger patients, it's very tricky to try to bring these commissures, building it outside the pulmonary artery, because you're going to be in the back. So either it will be easier, of course, in a primary case, because you can dissect easily behind the PA and get this commissures built. But I found that maybe in this position, you'll have to do this inside the pulmonary artery, which we have done. And with the less pressure and a forgiving nature, I don't think this will be that difficult to do inside the PA itself rather than outside. In the second the strategy, I'll tell you that we can transect the PA completely, move it to the front, and becomes like the aortic circle, and you can just do it this way. And so this is how the final picture more or less will be. This is again, we don't have answers for the durability of the procedures, and we don't have answers for the intermediate outcomes yet. We're talking about few months of producing these operations. So maybe in a different time we'll tell you if it works or doesn't work. But again, one of the challenges is in the smaller children, these leaflets are quite large. I mean, if we are talking about older children and teenagers, adults, this is not a problem. When you go down to the infants, I think it's challenging for several reasons. First of all, the first one we tried to do, we took a big sheet of pericardium, as you see, and then we realized that we can only make 2 leaflets from that. So when we went on bypass, I took the diaphragmatic pericardium, we harvested, and we created a similar leaflet from that. Also, another challenge is, while we're on bypass, because of hemodynamics, we reconstructed that pericardium with the Gore-Tex membrane as usual. This is a patient with pulmonary stenosis. With the leaflet are very dysplastic, can't really keep it. So excise the leaflet, made the sizing, and as you see, can extend this to varying degrees into the outflow tract. A lot of us know that already. And then in these patients in general, we try not to have wide open pulmonary regurgitation anymore to protect the right ventricle. So the reconstruction here has been varying between monocusp, 2-cusp, leaving the 2 leaflets in the back, and limited transannular patch. There's so many ways of doing that, but now maybe we can try to create a competent pulmonary valve in a better way. The advantage, as we all hear, there is the standardized way of measuring it. There is no brainer here that we cannot put bigger than the 13. It's already big, and we had to trim the leaflets a little bit after placing it. But it requires a little bit of imagination about the level where these leaflets will go, etc. And again, once we divide, we make this circle, I think it's easy to fashion your leaflet wherever you want. Once we did the leaflet, we were able to trim it a little bit, because I felt personally it was a little bit big. And one of the things I thinking about now is, in this age, maybe we need smaller sizes and a smaller leaflet surface area, because we don't want this leaflet to be big in the outflow tract, to be obstructing the RVOT. So at now sewing this anterior leaflet to this, building the commissures, and then after that we adjusted the height of the leaflet, and we trimmed part of it. This is the point where, when you reconstruct these, now the third one will be a little tricky to try to construct it outside the PA. You'll have to either shift the commissure so you can put the pleats on the outside, or just do it on the inside if you have enough room in the main pulmonary artery. There was this is the post-procedure echo. You can see it's always difficult to get a good picture on these, but you can see the leaflet mobility with trivial to mild PR, and gradient we got was about 20 across the outflow tract, so we accepted that for now. Now this is the second way that I think we can do it this way, but it probably require more of a generous pulmonary artery in adults or older children, or somebody who had a previous transannular patch, where you can completely transect the pulmonary artery and you have everything as a standard Ozaki, and you can build the commissures on the outside as expected. Is same sewing technique. There's not much difference. Now it's the material that where the debate is. What should we use? Some thoughts about, or at least in a reoperation so far, what we use is the gluteral, the photo oxidized bovine pericardium, because I feel the materials are good, and it's easy to build that. And the third thing is, like we have seen in the first presentation, I mean, a lot of these patients, we can make it in a conduit fashion because they are coming into needing a conduit. In fact, more or less, this can be replaced as a segment in the main pulmonary artery if it's big enough. And the basic principle is the same. You can build this also on the back table before even the operation, and do that in this fashion. This is the patient that I was just talking about, one leaflet reconstruction of a pulmonary Ozaki. And you can argue why we are doing a one leaflet. What's the difference between this and a monocusp, for example, in a tetralogy repair, or a single leaflet? So this patient had perfectly fine two functioning well-functioning pulmonary leaflets, native, and all what it needed really like an annular enlargement with closure of the of a small VSD at the same time. And this we did this about 3 months ago, and so far there is no RVOT obstruction, and the amount of regurgitation is only in the trivial to mild range. Again, a different view for that. So the one leaflet pulmonary Ozaki versus the monocusp, I believe that now with using this Ozaki sizer and templates, it is useful actually to setting a proper cusp size and creating the neocusp. And moreover, we could easily create a new pulmonary valve annulus for the neocusp around the RVOT. It also gives a better coaptation, and therefore this in dynamic interaction with the other two leaflets will be good to prevent any significant pulmonary regurgitation. Now these are more or less what potential benefits can be for the pulmonary Ozaki. Obviously the need for anticoagulation, that's now still a debate on a different centers what to use after placement of the pulmonary prosthesis. We shown that these bioprosthesis can thrombose, and maybe that contributes to this early failure as well. Hemodynamics with lower gradient based on the data similar from the aortic Ozaki, by absence of a rigid prosthesis in the outflow tract. The independent replacement of the cusps, I think, is more effective in preserving this natural motion and of the annulus, and also the dynamics between the right ventricle pulmonary valve annulus and the sinuses of Valsalva, as well as the pulmonary artery. We have to treat this similar to the aortic root complex to achieve a better hemodynamics. Maybe that's why these tissue valves degenerate earlier. We don't know, but there has to be some turbulence that creates these problems. We've all seen this picture of the normal aortic root and the aortic prosthesis and the AVNeo in the aortic position. And we can see the dynamics with the cardiac cycle almost similar to the normal. And there is no reason to think you can't achieve this picture in the pulmonary position as well. Maybe next time. But when you have this prosthesis, you can see there's really nothing there. It's just the heart is beating against something rigid. So the questions remaining now is the practicality of the procedure. Is it really practical to consider it in the pulmonary position? And the durability, and also feasibility of transcatheter options after Ozeki. I don't believe that the transcatheter options will go away, and I think it's complementary to these patients, and I think it's feasible to be done after previous Ozeki with no problems. There have been reports of this already, limited, but it has been done after aortic Ozeki as well. The durability, that's a time only that will give us this information. Practicality, I think there are some patients where this can be considered. It may take time to build up data about this procedure for the limitations that we mentioned. So moving forward, the smaller patients, neonates and infants, I think we will need almost like a separate pulmonary artery specific set or sizer, because I think there is room to do this in a better fashion in a smaller children, where you can actually have a good 3 leaflet coaptation. And we see a lot of them. The second thing is the autologous pericardial substitutes. To answer the question for these patients about the reoperations where there is no good autologous pericardium. As I said, there is a potential for thinking outside the box and trying to get the posterior or the diaphragmatic pericardium harvested. It probably will require in a lot of these patients to go on bypass to be able to do that without significant hemodynamic problems. But again, this will need time to prove this is feasible or not. And finally, the minimally invasive options. So if we have the right material, can we use it in a minimally invasive option to do an Ozeki? This is a minimally invasive pulmonary valve replacement that is done in a patient who had we've done it in a primary cases as well as those who had previous tetralogy of Fallot repair. So already you don't have enough pericardium, and once the limited lift anterior thoracotomy is performed, the lung is retracted and the pericardium is exposed to right there. This gives the access straight forward to the right ventricular outflow tract, and it's a very useful approach to consider. So once you get that, you have the ability actually to do that theoretically through this instead of boating the procedures. So I think there is a lot of options that we probably will see in the future. So in summary, the competition for the pulmonary Ozeki, I think, is tougher than the aortic because of the availability of the patients, as well as the reliable other option that has been there for years, and the ones that will be coming in the future. But there are potential candidates for these that maybe we should think about, such as neonates and infants, if we have the right setup for them, and as part of other repairs of congenital heart defects, such as closure of VSD or PA-plasty, etc. Those with large or native RVOT, if we at some point prove that the hemodynamics with the Ozeki in the pulmonary position is better, maybe that the durability actually will be even better than a standard bioprosthesis. So you can argue by offering this procedure. Endocarditis cases, this is a little bit tricky because I believe some of these endocarditis, while the indication seems to make sense, but that pericardium, I don't know what the nature of this pericardium is. And also there is some concerns about endocarditis after aortic Ozeki, which we've seen in the previous presentation as well, and consistent across the literature. So it's not a small risk, but it's there. Anticoagulation limitations or concerns, maybe, and we definitely will need a larger group or some sort of a multi-center study to get quicker data earlier. So I will finish here, and I'll be happy to have any questions Thank you for your invite today.
Thank you, Dr. Saeed. That was excellent, and I think gave us a lot of things to think about and consider as we go forward in the future. So let's get to some of the questions. We have about 30 minutes of time. So the first question came up was, and it can go either to Dr. Siva Kumar or to Dr. Syed or both, is what is your thoughts about truncus arteriosus and using the AVNeo procedure to actually repair the valve, even if it's quite abnormal or very abnormal, like a quad cuspid valve or something like that, taking into account a longer duration for cross clamp time. What do you think about using AVNeo in those type of patients? So Dr. Siva Kumar, I'll ask you first.
Thank you, Damon. Yes, we have used the AVNeo in truncus arteriosus, but I use it with a bit of a caution. I have performed it on 3 patients, and the 3 patients were in the younger age group. The first child was 2 years post truncus repair, had a severe truncal regurgitation. I repaired the truncal valve, and then in 2 years' time came back with severe regurgitation. So this time around, I went in and I did just a Ozaki without changing the conduit. The other 2 patients were slightly older, at about I think one was 6 and the other one was 8 years old. And for those 2 patients who had a previous Contegra, size 12, I performed AVNeo and change of conduit. In the same period, I had 3 other kids who came in with severe truncal valve regurgitation and stenosed conduit. But I opted not to do the AVNeo because they were older patients with very dilated annulus, size of about 21 and 23, and I opted to put in a mechanical valve and change the conduit. Now, in those 3 patients on whom I did the AVNeo, I think the concept remains the same. One of the patients had a quadricuspid valve, but it doesn't really matter. If you are quite confident in performing a tri-leaflet AVNeo on a unicuspid or a bicuspid valve, the principles remain the same. The key point is create 3 commissures, equal positions, and make sure you stay away from the coronary arteries. That's it. So if you have those principles in mind, even if it's a quadricuspid or if it's a bicuspid valve, or it really doesn't matter in the setting of a truncus arteriosus. Now, there are occasions in truncus, in one of those patients, the coronaries were quite close to each other, that is the right and the left. So that is pretty simple. If they are close to each other, then you just make sure that both the coronaries are within that one single cusp. So that the important thing is you just need to position your commissures in such a way that you get 3 equal size leaflets as equal as possible. Now, coming to the substitute material that you can use, well, in my practice, I only have the decellularized bovine pericardium, that's the cardiocell. And in all the 3 patients, I use the cardiocell. So far, they're done pretty all right, but I suppose I need to see how the the midterm and the long-term outcomes are going to be. So I would also extend this indication not only for truncus, but also for arterial switch, post-arterial switch with severe regurgitation. I have not done that yet, but I think if there is an indication to do, I think I will do it. Now, my only concern is that in severe aortic regurgitation with dilated annulus, I'm really not sure how the long-term outcomes of the AVNeo are going to be, because if the annulus is pretty smaller size and not very hugely dilated, it probably, I'm quite confident to do that. But in very dilated annulus, I am still a bit cautious. So that's the reason why I just don't go and do the AVNeo in all the cases. I select my patients. But of course, if they are younger patients with truncus arteriosus, I will certainly go ahead and do the AVNeo, and I never had any problems so far. Thank you.
Thank you. Dr. Said, what would your response be to that?
I will echo Dr. Siva Kumar. I actually it doesn't matter in my mind whether the bicuspid, unicuspid, quadricuspid, doesn't matter. The concept is the same. You want to create a circle and you want to create 3 equal leaflets. The question is what to use and what's the patient profile is. So for truncus patients, there are 2 types of patients. The first one where the neonate, where you have a bad truncal valve and you need to do the repair. So this is something that sometimes I didn't have this experience for in that situation. But also this is a patient who are quite sick and you want to get out of the OR in a reasonable fashion, but also with not a lot of regurgitation. So doing the Ozeki in these patients just has to go with being careful. In the reoperations, we've seen this more often, obviously, but also we have to be aware that the VSD patch it goes all the way down up to the aortic or the truncal valve. So it depends on where it was done, it was sewn, and how these leaflets are calcified. For example, you may not be able to sew the leaflet to this, and maybe in these patients with the large problematic truncal valve, this is a time for replacement with a mechanical procedure, which is I've done before in these patients. In a good scenario where everything is soft and you can sew to, I think you can easily reconstruct the tricuspid aortic valve or truncal valve in that scenario, following the Ozeki principle. And the nice thing about the truncus is the root is big. So that gives a room for good leaflets, of course. We've done more after VSD closure, as Dr. Siva Kumar described. After one cusp, usually the right or the right none gets stuck to the patch of the VSD, and the patient comes back with aortic regurgitation. In the reoperation, I've used the photo-oxidized material or the PhotoFix because that's where I have most experience with. The CardioCel, I don't use it for the leaflet reconstruction. That's my personal opinion.
Yeah, so that actually leads us right into the second question, which is what is your preferred or your recommended patch material? I know Dr. Siva Kumar talked a little bit about CardioCel, and Dr. Sayed talked obviously about PhotoFix. The literature on both of those products is a bit suspect, I would say, and we have to be careful when using either one of those. What do you recommend today? This time I'll start with Dr. Sayed. Are you using PhotoFix for AVNeo today?
For all leaflet reconstruction, I'm using PhotoFix. I've used it in the aortic position, in the pulmonary, and the tricuspid, in the mitral.
Okay.
I don't have the long-term data about it, but I feel from using it, but I used a CardioCel in the past, but I feel that the PhotoFix is more flexible a little bit, and there are some data. I agree with you. It's a little bit conflicting data, but there are some data goes in favor of the PhotoFix compared to the CardioCel.
Yeah.
But also remember there has been reports of dehiscence of the PhotoFix as well. So I think a technique matters is very important, and also I have noticed personally in the PhotoFix, and I talked to actually the company about this as well. The thickness of the PhotoFix sometimes are not uniform. So when you bring the patch, I will choose the part that's a little bit thin if I am doing a leaflet reconstruction, like 0.4 or something. They give you the range of thickness, which is, we have to notice, be careful with. Look at the thickness on the patch, because they will tell you it's somewhere between 0.4 and 0.8. Or something like that. So maybe before you cut the patch, look at it, and if you are using it for aortic root enlargement, it doesn't matter. I'll use whatever I have. But when I use it for a leaflet, I try to pick up the part that's a little bit less thick compared to the other one, trying to simulate the normal anatomy, but nothing is perfect.
Yeah, exactly. Dr. Siva, how about
Yeah, I really don't have access to the photo fix, but I've only been using the CardioCell. I take to account what Dr. Saeed has mentioned about the handling of CardioCell. But of course, now you have a finer version of the CardioCell. That's the CardioCell Neo. That's the thinner version, and that is what I am currently using. And that gives a bit more of better handling of especially when it comes to valve repairs. And so my practice is at the moment is using the CardioCell Neo for all the valve reconstructions in the AVNeo procedure, especially for redo. Of course, if it's a primary case, it's always autologous pericardium. There's no doubt about it.
Right. Yeah.
And I want to share with you. I just added at the end of the presentation because I was expecting somebody will ask about it. If I share the screen for a second, if you don't mind.
Absolutely. Please.
Let's see. This is screen 2. Sorry.
Seeing your echo now.
Yeah, I'm trying to. This is So this is after photo fix patch, and you can see the leaflets. So far so good from a coaptation length, and this is getting closer to a year now after the procedure, with very little regurgitation and a good outflow tract gradient. This is a patient who had a previous repair of sinus venosus ASD, and all his pericardium is gone. So with the redo again, you can say, why don't we take the posterior pericardium or the diaphragmatic? But to me, yes, you can do it. We do it in pericardiectomy and things like that. But I don't know about the quality of that pericardium as well. The diaphragmatic is always much thicker, require a little bit extra dissection. But this one shows a good mobility so far with it. So we'll see.
Okay.
I agree with Dr. Said on the usage of in the redo the diaphragmatic and the posterior pericardium. You can probably use it if you want to do some pulmonary artery or reconstruction. But I think when it comes to valve reconstruction, I'm really not very certain whether that quality of the pericardium is suitable to reconstruct a valve.
Hey, Damon, this is Chris Beard. Can I just make a comment?
Absolutely, Chris, go ahead.
So I feel I have to chime in here on the photo fix because unfortunately, in our experience now, I was a big advocate for photo fix. In our series of over 120, I guess, patients, and nearly half or just under half were photo fix. Unfortunately, what we've seen, almost all of our redos now in our 3 leaflet are photo fix related. And out of the series, we probably have 12, 15 redos. Every one of them except one was photo fix. And the mechanism of failure is all the same. And generally it occurs close to 2 years out. And it's exactly what was reported when the photo fix was originally used in a bioprosthetic valve, dehest off the annulus. And that's exactly what we've seen. And in fact, what you see is that the sutures pull through the photo fix. It's not that the suture breaks, it's not that it pulls through the annulus, but the tissue never becomes well incorporated. So this has been repeated to us now a number of times. So we've really stopped using the photo fix. I was, as I said, a big advocate. I've even on times used it as a primary because it tended to handle nicely. It gave an excellent appearing coaptation, excellent early result. When I have had to use it, or if I have, I've reinforced that suture line with pericardial pledgeted sutures to try to obviate this problem late. So I'm going to try to put this experience out there in the literature so people are aware, but it's, we now try to avoid it and use autologous. The CardioSil, I think plenty's been said about it. The UK experience had some failures. We've seen failures with it. We've used both the CardioSil Neo as well as the CardioSil. So in our hands now, we generally try to find autologous at all cost.
And Dr. Baird, thanks for your input and for your larger experience, which we're all learning from as well. So you're changing your choice now to try to find autologous pericardium. You abandoned
I think we have to, based on this experience. I just put together a synopsis of our experience, and it's pretty amazing. Every single pathology specimen that has come back is the same. And it never occurs before a year and a half. It's always late, and it's almost, the regurgitation's not usually central. It's at the annulus, and it's progressive, and it can get pretty significant pretty quickly. So at least now, having said that, we obviously have a number of patients that have PhotoFix that are doing fine with a perfect looking valve at 2 years. So it's just unreliable, but I think it has to do, and again, this is not the first time we've seen it. As I pointed out, when PhotoFix was first brought out, it was put on a stent and a bioprosthetic valve, and I think they were maybe 10 implanted, and a couple of those failed early, and it was removed from the market immediately, and it failed in exactly this way. So I think history is repeating itself a little bit here in our experience. So again, I think if you have to use it, then maybe just intermittent tacking sutures of autologous pericardium to try to provide some more support until we find a better tissue.
And
Chris, it's Danny Chu here. Sorry to interrupt. I know this is a congenital base, but I guess the question is, how is that different? How is PhotoFix different than chemically structured than CardioCel or say other bovine pericardium?
It's treated. Yeah, it's treated very different in terms of the cross-linking, and so when it's fixed, the way it's fixed, it's photo-oxidized, and so when they fix with glutaraldehyde, the tissues are completely structurally different. So what's happening is with the PhotoFixed pericardium, the native autologous annular cells are not ingrowing into the PhotoFix. And so we've taken these tissues now and looked at them when we've taken them out, and you don't see any ingrowth into the pericardium. Whereas with CardioSil Neo, you'll get ingrowth and incorporation. The CardioSil doesn't fail in the same way at all. You know, CardioSil fails with calcification, not dehiscence.
Yeah.
So it's the structure it's just the structure of the tissue and the way it's fixed. You know, it's very different. But one of the advantages is it doesn't really calcify. So that's why we picked it up early on and thought it was going to be a nice solution.
And what did you notice so far with the autologous pericardium in a reoperation? Have you started using it already?
You mean in our reoperations, we tend to use autologous, and admittedly, we see it just like you guys do. It's roughened up, it's thinned out. I'm pretty aggressive on it. Even when I have to take the diaphragmatic or posterior pericardium, we stretch it out and really work to debride it, if you will, from all the fibers and rough tissue. So again, we don't necessarily think it's going to be the best in the long term, but I think it right now is probably the best that we have. And interestingly enough, in our series of ones that we've used redo, I mean, more than probably 3/4 of our patients are redos for aortic valve. You know, they've either had a valve repair elsewhere or one of ours from years before of one of the different techniques. So most of them are redos, and we've been able to clean that pericardium off. So as the series gets bigger, we'll have, you know, a better sense of that to see. And as everybody's aware, now that the Ozaki registry is being established, both national and international, hopefully all of these details will be able to be elucidated quicker and on a broader scale.
That's
And
great
have
point.
you changed your way of fixing it in glutaraldehyde in the reoperation, or it's still the same duration?
Yeah, so we generally treat it for a very short period of time. And it's the same whether it's a reoperation or not. And then, of course, the importance is to do the washes, 6-minute washes,
Yeah.
3 of them. Probably the point is a lot of wash for a long time that's repeated to remove the excess glutathione.
But
Thank
your Chris, your current time is 2 or 3 minutes.
Yeah, generally 2 minutes. Again, we don't know that that's necessarily better than 3 minutes, but
Right.
probably less is more.
Yeah.
But
Okay, great. Thanks both to you and to Dr. Chu for your comments.
I'm sorry, quick question again. 2 minutes
Danny.
glutathione fix? Chris?
2 minutes for 2 minutes for autologous is what we do. Yes.
Oh, this is for kids, right?
Well, it's for any of our, even our older than 18-year-old patients, we do 2 minutes.
Really? Because
Ozaki's now come down also. I think his time is more like 5 minutes, but he started at 30 minutes, and I think that's slowly come down over the years.
I'm still doing the 10 minutes per his paper and protocol. I'm wondering if I should change that. It's worked well for me, at least for my series.
Yeah, I wouldn't change. I'm not suggesting you change it. I would, again, wait till the experience accumulates here and we look at a larger group. And
I got you.
yeah.
Okay, thank you.
Great. Thank you both. Thank all of you for those comments. It's excellent discussion. Another question came up to both of you, Dr. Siva Kumar and Dr. Sayed, about the Ross procedure. So both of you kind of mentioned the Ross procedure during your talks, and the question comes up is, when are you recommending to do Ross? When are you recommending to do AVNeo? And how are you differentiating between the patients when you do one or the other procedure? So Dr. Siva Kumar, you can start this then.
Right. Thanks, Damon. I think, as I already mentioned, the problem is we are having difficulties in acquiring the pulmonary homograft. And I think from the outcomes of the Ross operation, it's clear cut that if you have the pulmonary homograft, then you have a better long-term freedom from reintervention on the RVOT. And so what we are now doing is, if it's only absolutely necessary, like in infants where we can't do the Ozaki, where we'll need some kind of a root enlargement like a Ross-Kono operation, then we will do the Ross. If not, in all other cases, we have totally shifted away from the Ross operation and we are doing the Ozaki procedure. The youngest patient that we did the Ozaki is 2 years of age. So I think we are quite comfortable in that age group to perform the AVNeo. So I think we have almost kind of ceased of doing the Ross operations, except in smaller patients. So our main limitation is that we don't have access to pulmonary homographs. Yeah. And I think doing the modified Ross using other conduits, I'm really not very certain that they will be durable in the long term. So, and many of our patients also are in the rheumatic pathology, and it's very clear cut that the autograft dilatation in the long term is pretty severe in the rheumatic population, and we are totally stopped the Ross operation in that group. So we are more towards the AVNeo than the Ross.
Okay, Dr. Sayed?
We're still doing, I will say, Ross, and my personal approach now changed a little bit into trying to postpone the Ross till they are fully grown. So I will say if I see a teenager, probably maybe go ahead and offer the ROS. If I see, somebody, infant or smaller child, I'll probably try to offer the Ozaki as a first step. It doesn't burn any bridges. You still can do the ROS after the Ozaki. And that's how I discuss it with the parents about the excellent hemodynamics of both. The no need for anticoagulation, as we know. However, we don't have long-term data for the Ozaki, and it's a discussion always.
Right.
There is so as long as you brought this point up, there is a recent paper that I think published a small series comparing Ozaki with ROS. And to me, it's a little bit premature to discuss this because you don't have long-term data. But let me show you what the authors noticed, which I think we all noticed, but they just put it in writing.
And this is the group from Italy, right?
I believe so, yes. It was just in pediatric cardiology. Let's see if you can see it. Yeah. 38 patients, 22 Ozaki and 16 ROS, all children. And when you look at the progression of aortic stenosis in the Ozaki versus the ROS group, you can see preoperative on both group, there is significant drop in the gradient after the Ozaki and after the ROS, which is what you expect with a good procedure with excellent hemodynamics. Now, during the follow-up, you can start seeing that the gradient start to increase a little bit more in the Ozaki group compared to the ROS group, which maintain that gradient for a good number of years before you start seeing this. So this is an early slide, of course, because the follow-up is limited. And when you look at the aortic regurgitation, again, improvement in both pre comparison to post with an excellent result. They both leak, the Ozaki and the ROS, and the leakage is not significant between either during that early part of the follow-up. And of course, with this early follow-up, there's no difference, but it's only obviously a matter of time to before we know more information. So this is an argument that you can do the Ozaki as an initial step for all the children prior to committing them to two valve operations and enjoy between the Ozaki and the ROS a good quality of life for the majority of their lives with no problems. Plus also when we do the ROS in the teenagers and older, we start to wrap the autograft with Dacron, and we do a lot of maneuvers to try to minimize this reintervention rate, etc. So there's a lot more you can do when they are fully grown compared to when they are children.
Okay, great. Thank you very much. Good comments. So we just have a couple more minutes, and we have to have a question on the pulmonary valve, of course, Dr. Sayed. That's one of the things we wanted to talk about. So somebody asked, would you consider to a redo of the pulmonary valve using the AVNeo or the Ozaki procedure after you have a biovalve degeneration?
I was actually close to do it in the last case, and I chickened out because and maybe Dr. Beard can help me here with this as well, because I got into, and I was planning, I will take the bioprosthesis because just the justification for that is this child had failure of the bioprosthesis in less than 5 years after the initial placement. So I discussed it, and I was planning to try to put a different type of reconstruction. And also we thought that there could be an issue with the valve thrombosis and limitation for need anticoagulation, etc. And then when I got in, it was a very difficult to redo. It took a while to take the older prosthesis out, reconstruct things. I didn't want to add more time on bump with a chance of failure, so I just replaced it. But I was thinking about it. Yes, I don't know if anybody else had a similar experience, but some of these videos are unpredictable, how easy or how difficult they will be.
Yeah, unfortunately, I think Dr. Baird left. He had to go to the OR. So, The last question with the last couple minutes. So you talked a little bit, Dr. Sayed, about using the 13 sizer, which is obviously the smallest one we have. And typically when we talk about the 13 in the aorta, we talk about an annulus of something like 10. When you're talking about your need for these smaller patients, what size of the annulus are you talking about for the pulmonary?
Well, I don't, it makes sense when you have the annulus 1 centimeter. So we can reach an annulus on the pulmonary position as 1 centimeter. However, for some reason, it was, or it felt like it's very crowded in the pulmonary artery. And maybe it has to do with the orientation or the pressure. Maybe the pressure in the pulmonary circulation does not open the leaflet as good as you expect in the aortic position. So you end up by having a gradient from the leaflets that you reconstructed. So I think there is a little bit of technical difference and physiological difference between them, that it is justified to think about making a smaller size leaflet, especially in smaller children.
Okay.
I don't think it matters in the older ones. I think you can perfectly do the exact techniques, but I think there is room to create a smaller sizer for infants. So remember that the smallest patients, you can enlarge the pulmonary artery as you want, but you're going to transfer the gradient down the road in the PA branches, and you don't want to do that in a patient who does not have pulmonary artery branch problem.
Right. Okay. Great. Dr. Siva Kumar, have you thought about doing the pulmonary valve replacement with the AVNeo?
I'm kind of encouraged from Dr. Said's presentation about performing it. We have because I'm quite interested to use it, especially in this group of patients with pulmonary atresia and intact ventricular septum. Most of these patients have a balloon valvotomy performed, and they have a significant pulmonary regurgitation. And when they come in for either overhaul operation or for a 1.5 ventricle repair, that pulmonary annulus is fairly, looking, the pulmonary artery looks pretty dilated, though the annulus is not that big, because there is still some kind of stenosis. The pulmonary artery looks a bit dilated. So I think probably, that kind of patients, once you open up into the RVOT, you probably might get a fairly roomy kind of space to implant the pulmonary valve. What I'm thinking is, Dr. Syed, probably if you use the 13, leaflet, we place the dots where we're going to place the sutures. Probably we can use that dots to cut the leaflet even further to a smaller size, and then shift your dots a bit, another 1 millimeter forward, and then probably that might give a smaller configuration. I don't know whether that will work. It's just some kind of improvisation. Probably we could consider that.
I think this is a good points too, and again, the nice thing about the Ozeki is the ability to standardize the procedure by sizers and everything, so you don't have to improvise too much, which contribute to success of the procedure. Because obviously we know the idea of autologous pericardium use for leaflets are not new. It's just the way it's being standardized is good. Now the other comment I want to make is I may brought this up into the slide about the forgiving nature of the pulmonary valve. We all get into the mind of putting or sewing the leaflets where the annulus is. You don't have to do that in the pulmonary position. I've done pulmonary prosthesis replacement many times in the main pulmonary artery, away from the right ventricle at all, for other reasons that was not related to the leaflets, etc. So these are also the absence of a coronary and an absence of other tricky situations in the aortic position make it easier for the pulmonary to be handled easier.
Yeah. My only concern I want to ask you, Dr. Syed, is that if we are using these materials other than autologous pericardium in the pulmonary position, So that's a low flow, that's a low flow, circuit. So will the chances of calcification be, more rapid in that case, or what is your experience on that?
We can extrapolate some experience from monocusps and things that have been used already with tetralogy related to the material. Well, in my mind, the calcifications and the degeneration has to do in part maybe with the material, yes, but also with the hemodynamics. So in the aortic position, higher pressure, turbulence, things like that, there has to be a price for these. In the pulmonary position, you see it with the rigid prosthesis because there's always turbulence of the blood and there's always a gradient. If we can eliminate that with the Ozaki, maybe we will have a better longevity. And as you say, it's a low profile, a low pressure circulation. Maybe it will last longer in the pulmonary position compared to the aortic with the same material. So there's a lot of questions really, and just need to convince our cardiology colleagues to help us. But it's difficult for them to change their practice sometimes.
Yes, definitely. And there's a lot of great questions and a lot of great things to think about as we go forward. So we're out of time, unfortunately, but I'd like to again thank Dr. Siva Kumar and Dr. Sayed for your time today and both of your presentations. I think they were both excellent, and I think the feedback I'm getting on the chat, everybody is very appreciative to hear your experiences and your thoughts. So thank you very much for your time, and we look forward to continuing to explore the ideas of new autologous pericardium as well as the pulmonary valve replacement. So thank you very much for your time, and we look forward to seeing you soon. Take care.
Thank you very much, and thanks for everybody who showed up today. And hopefully next time we'll have more solid answers that will help everyone.
Yes,
Thank you.
Thank you. Appreciate it.